Happy Wednesday, everyone, and welcome to Within Summit. My name is Ashley Barkoviak, and I'm the Clinical Operations Coordinator here at Within Health. Today, I'd like to introduce you to our three presenters. Randy is the founder and director of B Collaborative Care, a center for eating recovery. She has seen over 7 years of experience in providing comprehensive and evidence-based treatment for individuals with eating disorders and related issues. She is a registered dietitian and holds a dual master's degree in health communication and clinical nutrition from Tufts University. Their mission is to help clients heal their relationship with food and their body and to promote a culture of health and wellness in the community. She is a nutrition expert and a media professional with 20 years of experience as the managing editor of Nutrition Today, a peer-reviewed publication that covers the most current and controversial topics in nutrition and health. She has appeared in national and international media outlets such as CNN, ABC, and NPR to share her insights and expertise on eating disorders, sports nutrition, women's health, and body image. We also have joining us today, Katie. Katie is serving as one of our clinical leads here at Within Health. Through work deeply rooted in the principles of HAES and intuitive eating, and within an integrated attachment-focused framework, Katie helps clients realign with their most authentic selves. Recovery is a process of discovery, change, and a development of a greater sense of safety and trust. Katie holds a master's in clinical psychology from Antioch University, Los Angeles, and a Bachelor of Arts from New York University. Thank you, Katie. And last but certainly not least, we have Dr. Sean Ribel serving as our clinical chief officer here at Within Health. Dr. Ribel provides trauma-informed nutrition therapy to individuals struggling with disorder eating and eating disorders. His passions for this population began with his master thesis studying eating disorders in male cyclists, and he continues to explore eating disorder behaviors during his doctoral work. Dr. Ribel has held assistant professorships at UNC Chapel Hill and the University of Mississippi, as well as a research position with Duke University. With over 15 years of clinical experience, he promotes freedom, flexibility, and nourishment with food while providing compassionate, evidence-based care. We're so excited to have all three of you here presenting with us today for Summit. So welcome to you all. Before we kick things off, though, I do have some general information to go over in regards to the CEU and the CME credits. For all CME credits, please email myself or Jamie Singletary. I will provide both of our emails in the chat. We will make sure we get those CMEs over to you. In regards to the CEU credits, there will be evaluations that will be sent to your email you use for registering for this presentation. Once the evaluation is complete, you will receive a link to download your CE certificate, and please utilize that CEGO dashboard. The slides will not be provided today. However, there will be a recording of the presentation available. You will not get credit for watching the recording. You do have to attend live today, so please make note of that. Other than that, again, I will provide my email, Jamie's email, and also the CEGO support information. So if there's anything you need additionally, we will have all of those resources. Also, please utilize the chat function or the QA function today if any questions do arise. And I am so excited to have all three of you here today and to hear this presentation. Thank you all.
Cool. Thank you so much, Ashley. It's a pleasure to be with everyone. We thank you guys for taking a time out of your day to spend some time with us. So we're going to dive right in. First and foremost, we just wanted to provide some disclosures here, and you could see those on the screen. We did want to provide an acknowledgement. Dr. Caitlin Shepard, who is the Director of Clinical Research at Within, she is somebody that has played a major role in helping us at the initial stages of this talk over a year ago, y'all. Can you believe? I can't believe how long we've been. So this isn't, yeah, so but we just wanted to give a shout to Dr. Shepard. We thank her for helping us at the initial stages of this and for her continued support. We wanted to make sure that you guys walked away with some takeaways that can be useful for just not only like head knowledge, but practical knowledge as well. So here are our learning objectives. We want to make sure that after this, you'll be able to describe 3 ways in which GLP drugs are different from the other diet drugs, explain 2 benefits and 2 side effects of these GLP medications, and as well identify 2 different variations of the compounds used in commercial medication use. We do want to let you guys know that we're presenting like common examples of what people experience, what we see as clinicians, but also what we've heard from our clients and our patients anecdotally. And so with that, we want to let you know that there will be some language that we're going to be using that necessarily doesn't mean we all agree with it, but it might be pretty hard to hear or even a little upsetting. And that means we're going to be talking about numbers, weights, going to use terms such as obesity and things like that. That's not, again, to say that we agree with those language or with that language or those terms. We're communicating what it is and what we see in the literature and some of the things that we face as we walk through this. Just to give you guys a little idea of the flow of where we're going to go today, we're going to set up like what the concern is, like with these GLP-1s, like what's the concern, kind of setting the stage. Then we're going to look at a historical view of weight loss drugs and then go into the newer meds and some of their mechanisms. Then we'll hit up a case study a little bit and then get into the psychological implications, including food noise and weight cycling. And then we'll finish it up with some considerations when working with eating disorder clients. So that's where we're headed today. And I'm going to pass the mic over to Randy.
Fantastic. Thanks, Sean. So if you see this lovely image in front of you, and if any of you, sort of have the visual learning that I do, and you sort of look up like this when you're trying to think about something, this is how I spent most of my graduate school career, looking at something very similar to this. And it says, it's a quote by Maimonides, and it says, "Teach your tongue to say, I don't know, and you will succeed." And I think that it's really important as we're setting up the landscape of this discussion, and really, I think in leading in with curiosity as practitioners, that there is so much that we don't know. And I think it's really important to recognize that. And that is also a powerful answer. We can, let me find out for you. Let me get back to you on that. And I think in terms of this particular presentation, one thing that is why this came up for me was, when I first saw the GLP-1s coming into my my office, I didn't know. I wasn't sure. There's still things that we don't know. And I think leading with that curiosity and ability to find out is really something that's significant. Sean, can you forward to the next slide, please? So I wanted to say, if we think about where have we been hearing about this, and I say we, I use the proverbial we as individuals. I think, when we're, in my experience, coming the first time that I've heard about a GLP-1, was back in graduate school and sort of understanding sort of hormone mechanisms and other things. But really, as a in the last number of years, I can say that who is coming into the room is really looking at this as the people that we're working with. And the magic bullet theory, which is what you see on the screen, is literally a substance that has the power to destroy pathogens, right? So we'll get into science early. Sean, just a little preview. It's been theorized to believe that an audience can be swayed by the message of the person who's creating the idea. So who's starting this? Patients don't want weight loss out of nowhere. Often they get the idea from, wait for it for a sec, not surprisingly, healthcare practitioners, which, by the way, all of us are, mental health, physical health, we all are healthcare practitioners. So, part of solving the harm that has been done around this is acknowledging that healthcare practitioners, many of those who have been misinformed themselves, have misinformed people and created a situation where people think that weight loss is the only solution to health. And it creates a systemic situation where then the blame gets back to the person, that they're blamed for their failures to lose weight long term, even though, as I think I'm preaching to the choir here, that the research is clear that this happens to almost everyone. When someone asks for weight loss, though, I think it's an interesting moment to look at this and think, this is an opportunity. Here's the conversation that you've wanted to have with somebody. It gives you the chance to help somebody to shift their thinking in a way that actually can help them release some internal stigma and move to a path to support their personal health goals. When we look at who's coming in the room with, the GLP-1s, these were, from the get-go, sort of under the radar. This is an endo situation. And if you have diabetes, and that might be a way to treat this, But it was very clear that once the side effects showed that weight loss was also a side effect of these medications, that then they became the impetus for another way that, practitioners said, I can help you feel better. And I think that's important to recognize that, I don't think that any healthcare practitioner has the intention to misinform their patients, but part of what we're hoping to do today is to really show you how these work and give you more information and what we do know. So if we think about, where do people get these, GLP-1s from, right? So if we think about the idea of, I was recently listening to a podcast and a psychiatrist was on and she was listing all the reasons, like how she determines whether or not someone needs a GLP-1. And so it's kind of interesting that that's made its way into sort of like the mental headspace of like, it's more of a mental brain thing, but people don't want this out of nowhere. They get the idea from, their healthcare providers. And I think the idea that like a PCP is not Dr. Google is really important. A physician has gone to medical school. However, remember back to that first slide, they also may not know. I think at this point, it's pretty safe to say that we're, this is now, at a space where most physicians are pretty aware of GLP-1s and understand the mechanism. And here's the thing, we still don't know the long-term effects of these. So they're, again, it's like looking at this and getting this information from your physician or a physician. And, in the best of intentions, let's go back to the idea, is weight loss the way to like sort of fix health? And I think that's a major part in weight bias as well. A psychiatrist, I feel like the case study that I'll talk about, that's actually how this started for this person. We hear it from drug manufacturers. So, you can probably, we can all sing that familiar tune. I don't know, am I allowed to say it in this audience? I feel like the Ozempic, we all know that the commercials. I feel like you can, even my 6-year-old nephew sings it around the house, and has no idea what he's saying. But I think that's, they're catchy tunes, and it's like, wait a second, here's, is this something? Weight loss programs. So if you sign up for a weight loss program, and again, that's, just if someone's thinking, oh, well, for whatever reason, they're actually co-prescribing these different medications in the context of this. You look into a mental clarity program, and would you like Ozempic with that? It's like a side of Ozempic is now kind of like offered as like the plus one to almost every sort of wellness program that's out there. And I think my my favorite example of where do we get these from is actually the hairdresser, which is again, this is purely anecdotal, but it was true. I did hear this from one of my clients who shared that the hairdresser was offering Ozempic parties and prescriptions. And what is alarming about this, other than the fact that a hairdresser, like who's prescribing this, how do we get this, is that it was actually compounded. And I think that that's a really important thing to recognize, is that when we're getting, a lot of the information that we're receiving, if it's a PCP, most likely they're prescribing something that's going to be and again, we'll talk about all of the reasons to prescribe and when is it indicated, is it not, but most of the top 4 are, sources that are going to prescribe a like actual amount of whatever drug, whether we condone it or not, and it's a pure form. In the case of the hairdresser party, it was a compounded drug. We actually don't know what it's cut with. We don't know what else is in that drug. There are like the idea of like, and this is the natural Ozempic. It's kind of scary to think about what we're in general, what we're putting into our bodies. I think the scarier part is that in this kind of situation, there is also a significant, potential health risk that needs to be addressed as well. So if we're really looking at, I'm going to turn it over to Katie to talk about the issues of like sort of how the idea of this broader topic of social justice and in weight loss culture, like why are people going to their hairdresser to not just get a haircut?
Thanks so much, Randy. So, one thing that's so important to remember, just to touch on one of your points, Randy, is that, not all doctors are educated in eating disorders. Not all healthcare practitioners, mental health or otherwise, are educated in eating disorders. Most practitioners are engaged sort of in their own beliefs and own weight bias. They also exist in diet culture, and first do no harm, certainly. And many practitioners may think that prescribing somebody a GLP is actually a health promoting item for that person. And especially when practitioners don't know about a client's eating disorder history, or think that because somebody is in recovery means that they no longer are at risk for relapse. These are really important things to discuss with clients when they say happily, oh, my, XYZ practitioner is going to give me a prescription for GLPs. Randy, you raised your hand. Do you want to ask a question? No? Okay. Thank you. I was like, all right. And it's also important when we look at this through the lens of social justice to look at our healthcare system in our country and think about who has access to doctors, and then who has access to specialists, and then what sorts of things are being prescribed and to who can afford these drugs, right? And then when we look further at what bodies are employable, what bodies make the most money, what bodies have most access to healthcare, we begin to look at intersectionality of marginalized bodies and the greater systems at play in our country. So diet culture is insidious, and it subsumes every facet of our society, from medicine to headline news to the dinner table and playground and every place in between. And the drive for the promise of a socially valuable body contributes directly to the temptation for many to abandon the hard work of body acceptance and on a personal level, even with the knowledge of the risk of rebound weight cycling and all of the other side effects of GLPs that might not be so pleasant. Diet culture mandates that acceptable and valuable bodies really come just in one size and one color. And the further a person is from that size, or striving to be that size, the less valuable that person the less value that person has, and the less access that person should have and does have to privileges afforded to those who do meet the socially acceptable standard of beauty. Obviously, all humans are equally as intrinsically valuable. It's just diet culture and other systems of oppression that spur us to have these moments of forgetting that all humans are actually equally as valuable, and make us think that there is a hierarchy of human value. While fear of fatness acutely harms those in larger bodies with specific discrimination, average and small bodies are also harmed and traumatized by diet culture. And although some prescribers appear to consider patient appropriateness for GLP use, it's clear from the skyrocketing prevalence of use and from the proliferation of startups, consumer reliance upon compounding pharmacies, and well-known commercial weight loss companies, and even manufacturers eager to provide these medications, that health improvement isn't necessarily the primary concern for people prescribing or demanding these drugs. Like their predecessor medications, these novel pharmacologic agents are prescribed liberally and to people who don't always fit the intended population, to the extent that even in recent years, the frenzied popularity of these drugs has really contributed to a shortage of these drugs, such that those with conditions like type 2 diabetes haven't actually been able to access medication. And that draws another great divide, right, in who is getting this medication, because who can pay for it, who can travel around to many different pharmacies to find it, and who is able to access it only through their insurance company, and then may not even be able to access medication because there's a shortage. Next slide, please. In recent years, the body positivity movement and health at every size, HAES, which is rooted in the decades of tireless work of fat liberation activists, it was begun by Black women, have made progress in opening the minds of clinicians and lay folks to the particular harm done to marginalized bodies by weight-centered and BMI-based medicine. Well, I guess another important thing to consider here is the idea that clients with eating disorders are being prescribed GLPs sometimes as a solution to the eating disorder. And the science hasn't changed, right? We can't solve eating disorders or weight stigma by eliminating fat people, right? Fat people will exist. Body diversity is a wonderful, and I would even say like biologically necessary thing to have for the future of humankind. And by trying to eliminate fat people, we're doing a huge disservice to biodiversity, to make a grand statement. Perpetuation of diet culture norms are contributory to the development of eating disorders, as are systems of oppression, and weight stigma is one. As clinicians, we really have to be aware that many people who take GLPs for weight loss are looking for a way to lose as much weight as possible, as quickly as they possibly can. They're not interested in like using this drug for weight loss as it was intended, and that's problematic anyhow, right? If we really look at intentional weight loss, what drives the desire for intentional weight loss, and what happens when people lose a significant amount of weight, and then we know that weight loss is not sustainable long-term for most people, then what happens later? Are we prolonging the inevitable? And we'll talk about weight cycling some more later on in this chat. Sean, I will turn the next one over to you.
Thank you, Katie, and excuse me, y'all. I know just with me with some of the controls here getting slow with unmuting and then also changing the slides, but thank you. But so when Katie's talking about the whole social impact of this, we can't ignore the biological impact as well. And when we think of this, I love this diagram by Jess Campbell. If you guys have seen this before, I know, Katie, we've discussed this. Like we've used this for a while when meeting with clients and helping them understand things. But what we wanted to drive home was that neurologically and biochemically, a brain that is undernourished is going to be different from when it's adequately nourished. And this isn't just in small bodies. These changes happen regardless of body size, despite what you might see on social media that like, oh, like you have to do whatever. That's going to impact our clients. That's going to impact when these drugs come into play. How so? Well, we'll get into the mechanism shortly, but the consequences of a starved brain happen at any body size. And these GLP-1s, how they interfere with the natural neural feedback mechanisms and the feedback loops that we have in our brain, they are going to be impaired to let the body know like, hey, starvation's going on here. And so that's something that we need to account for, especially in this role that we play as clinicians. Katie, was there anything you want to add on that one?
I mean, I think we could talk about this slide for like a seminar of its own. I think you stated everything I would want to say. Maybe looking more deeply into the idea that a GLP does like take away hunger, right? It does reduce hunger. It's an appetite suppressant. But it doesn't mean that the brain itself isn't undergoing the same issues as a starving brain without a GLP. So it doesn't mean we're not at it doesn't take away risk of, all of the cognitive inflexibility, at a far end of the spectrum, the atrophy of brain in a malnourished body. It doesn't remove any of these risks. It just makes them less unbearable, if that's an okay way to put it, for the person taking the GLP. And so there's increased ease of starvation with these drugs.
Thank you. Cool. So with that said, one of the things we wanted to move on to is, okay, what are these GLP-1s? But first, let's look at how we got to where we are today, right? So looking at these meds, the history of these agents used for weight loss, they're really marked by failure. And yes, I'm going to say it. They've been marked by failure because when they're on the market, they have these big hype, and then there's news then of the adverse effects, namely cardiovascular events. So we split this up into different sections, and one section that we thought would be helpful was agents that aim to reduce appetite or food intake, when you want to think of it like that, okay? So what we start off with are amphetamines, okay? They were first used to treat allergies and asthma and then narcolepsy, right? And this was in the 1930s, and specifically in the late 1930s, a study was published about the rate of the rate of weight loss when someone is on amphetamines. We had Apertrol in the 1930s, and then in 1937, so the late 1930s, there was abuse that was found to be happening. So they were known as pep pills or pepper uppers, and they have what you guys know of as side effects of that addiction there, right? Rainbow pills. So when you think about rainbow pills, there's not really consensus of what they were, but what we do know is that they were a combination of many different agents, mostly amphetamines, but then laxatives, thyroid hormones, etc. And that what Randy was talking about earlier about those compounded drugs. That's one thing that I hit it a little bit in another part of when we're talking about these agents is the supplement industry. And that's not to, point a finger or, say that somebody's bad, but the FDA is not regulating what's in these supplements. So when we're getting these supplements, there might be traces of other things in there. And that's one thing I know that Randy and myself as dietitians, and even Katie as a therapist, we faced with clients that are in this field, that we're treating in this field, especially when they're seeking this weight loss and those broken promises. But back to the rainbow pills. So they have those thyroid hormones. They were all different colors. That's why they were called rainbow pills. They were meant to curb appetite, which is similar to just the amphetamine in and of itself, but also promote weight loss. What you see on the right, the Clarko tabs, that's an example that included thyroid hormone, laxatives, diuretics, and digitalis. Digitalis is also known as digoxin. It's used to treat heart failure and heart rhythm problems. So I'm not going to get into the biochemistry of it, but just know that it's there. Amphetamines and specifically Clarko tabs and whatnot, these were all this use for weight loss were banned in the 1970s. They found that, hey, this isn't a good thing for our people. In 2015, however, though, the FDA approved Listix amphetamine, which you guys might know as Vyvanse for binge eating disorder, right? So we do want to say that it is still something that is available on the market. The next one I love, and I always love seeing the smiles on the faces of my co-presenters when my tongue trips me up on this one, but phenylpropylamine, it suppresses appetite. Yeah, it was all right, but anyway, it's a sympathomimetic. A sympathomimetic, what that means is that it acts as the sympathetic nervous system would. So it produces those physiological effects that are characteristic of a sympathetic response. In the 1930s, this was used to help with postoperative hypotension. So if you think about when you get startled, right? That's your sympathetic nervous system going to fight or flight. So when someone's blood pressure is low, they would use this to help increase that after surgery. In the 2000s, the FDA found that it increased the risk of hemorrhagic stroke, which means bleeding into the brain or to the tissue around the brain. So that's not good, right? And so that was something where it's like red flag there, right? All sympathomimetics can increase heart rate and blood pressure and cause insomnia, dry mouth, constipation, nervousness. There's a risk for myocardial infarction, heart attack, and stroke. But the main thing was that it was removed from the market because of that risk of that they found in specifically in females there. You might have heard of it as Dexatrim or Accutrim. Another drug that is used to reduce appetite, which makes sense when you think of, what anorexia is, not anorexia nervosa, but the anoretics, right? And then that's where we have phentermine. That's where that comes in here. But anoretics are medications derived from the chemical backbone of amphetamines. So they act like sympathomimetics, so activating that central nervous system response and affects specifically though the neurotransmitter norepinephrine. Okay, so when we talk about phentermine, it primarily works on decreasing appetite, working on the flowing out, so the efflux of norepinephrine from the brain. So when you look at some of the studies, some of the reports say anywhere from 8 to 20% weight decrease when compared to placebo. In 2019, there was over 75% of the anti-obesity drugs had phentermine in it. It has a less risk of toxicity versus others in its class with phentermine, but it is still a Schedule 4 drug, so there is some concern about dependence there. When we move on to topiramate, we see it's used to treat epilepsy and migraine headaches, sometimes alcohol dependence. Off-label use was for psychotropic drug-induced weight gain. It was trialed as a single agent, but didn't work well. And it came with memory loss and concentration problems. So it wasn't something that really stuck there, but we do see that still being utilized from time to time. The other thing that we see, fen-phen, everybody might be, some people might be familiar with that, but fenfluramine or dexfenfluramine, they're structurally similar to amphetamines again. Instead of mimicking the effects of norepinephrine in the brain, it acts to block the reuptake of serotonin at the nerve endings, and it might actually be an agonist of it as well, of serotonin as well. It reduces food intake because of that specifically, and there's new research looking at possibly for that and whatnot. But in the 90s, fen-phen came out, and that's where people data showed that people lost a significant amount of weight by combining both of fen-phen and sorry, I'm losing the name right now. My goodness. Phentermine. Thank you. Woo. But what we saw was a 16% weight loss versus 5% in placebo. And I know I'm just throwing numbers out there, but it's just to give context. You're going to hear these numbers with that, but just for an idea. One statistic that I found very interesting when we were originally going through this was that in 1994, the prescriptions for fenfluramine were mentioned less than 100,000 times among all prescriptions, right? In 1995, when fen-phen hit the market, the mentions of fenfluramine rose fivefold to over 500,000 prescriptions, and it peaked at nearly 4 million prescriptions. So that goes back to that social justice piece and the diet culture that Katie was talking about earlier, right? And then also even to what Randy was mentioning about those that are recommending these drugs. It's at what cost and why, right? Like, what are we chasing? What are we chasing as a culture here? The bad news about fen-phen, there were 12 cases of pulmonary hypertension that were reported. Boo, right? Bad news. But in the 1990s, in the New England Journal of Medicine, there was a 30% incident rate of those treated with fen-phen had valvular heart disease. So it was removed from the market in 1997. Last one on the bullet there, sibutramine. That's also known as Meridia. I'm old enough to remember the commercials for Meridia. I don't know if anybody else does. I can't tell you the context of them, but I remember seeing that on the TV. But it's a triple amine reuptake inhibitor. So what does that mean? Triple amine: norepinephrine, serotonin, and dopamine. So that's the triple amines right there. Okay. So it works by altering the neurotransmitters within the brain. It decreases appetite, raises blood pressure. There were some concerns with this one because there was cardiovascular events when used, but sibutramine can still be found illicitly in dietary supplements. So that's why we recommend so I say this, but if someone is taking a supplement, go with the USP or the NSF ones. Honestly, that's when you'll know what you're getting with them. Yes, they're a bit more costly, and I'm not saying that you need to do that. If your medical provider says so, that would be helpful, do so. But the NSF or USP ones are the ones to go for. We also I don't have here, that's an anoretic, is you have the combination of bupropion, which is Wellbutrin, as well as naltrexone. So those together also have some effects, but we'll move on here. We wanted to talk about two other categories. Ones that interfere with nutrient absorption. And so that's going to be orlistat, and the brand names of those are Ally and Xenical. I'm just mentioning those because those are common. I'm not saying, anything else about them, but that's what you would hear. That's orlistat. So orlistat is a lipase inhibitor. Okay, so it reduces the uptake of dietary fat from the gastrointestinal tract. So in other words, when the gastrointestinal enzymes make it, those enzymes aren't usable. They become basically inactivated, so they can't break down fat. So triglycerides cannot be broken down or converted into their free fatty acids and monoglycerides. So lipase is that enzyme that we're talking about here. Those like triglycerides that are undigested are not absorbed, resulting in a caloric deficit, right? That might have effects on weight control, supposedly. So in one trial, they found that 50% of people on orlistat and 31% on placebo lost 5% more of their weight. So 57, so about 55% and 30%, depending upon orlistat or placebo. So not a huge difference there with that. Another one that we have is sucrose polyester. You guys might have known about this one or heard about this one if you're around and from my generation here, but Olestra, it was the wow chip phenomenon. Everybody will probably, yeah, people remember that. But how is that formed, right? So to get into the science of it, what's going on there, it's formed from sucrose, or you're adding 5 fatty acids to a molecule of sucrose. And then that compound has the physical characteristics of a triglyceride. So they could add it to food, and it had the similar way of interacting with food from a food science standpoint, which when you think of it, that's pretty cool, right? But then you're like, wait, what is this going to do for your body? It can't be digested by pancreatic lipase. So we were just talking about that. When you can't digest pancreatic, and when you don't have lipase, when it becomes unusable, you're not digesting fat. So you're going to perhaps get into a caloric deficit from malabsorption, right? And we know that that's actually a nutrition diagnosis. Like, that's, go figure, right? But we're inducing that by taking something if we do choose to use this. But it found that there was some weight loss. Yay, right? Big deal. But I do like to highlight the downsides on these things, because when you're not absorbing fat, you're going to have a decrease in fat soluble vitamins. So mostly vitamin D, vitamin E, and beta carotene, in addition to lycopene. Those are polyphenols and things that we know have benefits for our health as well as our mental health. The other side effects are that, one, you're going to be running to the bathroom a lot. You're going to be going to do the number 2 a lot. So that's not fun. That's kind of impeding any social engagements, right? If you're going to have fecal urgency, you're going to be doing a poopy dance instead of a pee-pee dance. You're going to have abdominal cramps and gas. And the most socially awkward one is perhaps even some discharge while you pass gas, because, I know we all fought around our friends, right? But all joking aside, if you have some leakage there, that can be pretty embarrassing. So please don't eat Olestra. It's probably not in many foods now, but I haven't looked, so I don't even know. Okay, other one. ones that increase thermogenesis. Okay, so increasing that energy expenditure and thermogenesis. And so this is ephedrine and ephedra. You guys might have heard of these things before with the supplements. A lot of buzz for this on the news. Where did it come from? Ephedrine came in the 1970s in Denmark. I mentioned before with the amphetamines being sympathomimetics. Ephedrine is a sympathomimetic amine. It was utilized also to treat asthma, and they happened to find that it decreased weight. Okay, for those. Something, y'all, guys, I'm just coming to this, Katie and Randy, something I'm thinking about. And I know and I'm sorry, I don't mean to take time, but I want this for everybody. So I got into eating disorders by studying male cyclists, subclinical eating disorders in male cyclists. There's a lot of performance enhancing drug usage in male cyclists, specifically even using inhalers and asthma. There's a disproportionate amount of diagnoses of asthma. And I'm like, that's really interesting, because one, it's thought to open up the bronchi so that when you ride, you can get more oxygen delivery, et cetera, which would allow you to go further. But I'm just thinking of this now. I'm like, if they
Wait a second.
What's that? Wait, yeah.
I said,
like,
wait a second.
yeah, I'm like, wait a sec. Is this something they're using? Because if you guys see cyclists, yes, there's a variety of bodies, but mostly cyclists seem to be very lean, And so anyway, just sorry, squirrel, right? That I know I'm just dating myself doing that, but squirrel right there. So we have ephedrine. So there was a thermogenic food with thermogenic effect was boosted when you added caffeine to it. So there was some additional weight loss with that was seen. Main thing with it is that in the 90s, there were supplements marketed to treat obesity, and they contained ephedrine in them. And the reason that happens is because the 1994 Dietary Supplements and Health Education Act, it allows manufacturers to bypass FDA standards when providing safety and efficacy of these specific products when they're sold in the United States. So main thing is, and there's a big company out there that suppressed over 14,000 adverse events, like things like heart palpitations, dehydration, serious things like irregular heartbeat, heart attack, stroke, when they were taking these supplements that actually had ephedrine in them. FDA got wind of it and reviewed the data on these ephedrine alkaloids in 1997. They banned them in 2004, so that's 7 years. Took 7 years to get that stuff off. It was challenged and then ultimately put to rest in 2006. So that's 9 years of this stuff still being on the market, or potentially, I should say, potentially being on the market. So just wanted to put that out there. Again, with these compounding things and things that we don't know where we're going from, what are we chasing? What's the value? What are we looking for to do with our bodies? So we'll move on. So GLP-1s, why we came here today, right? But now you guys have a history of the drugs, at least a brief history. You'll see that there's some references in the bottom of the slides. If you're into it, if you want to read it, like there's some great historical context for most of these drugs, and even more than what we share here today. So what we have the not so new kids on the block. Why do I say the not so new kids on the block? Well, they've been around for a while. It's just the fact that now these recent trials that have come around, have been showing these big benefits. And when I say a while, I'm talking about 17, 15 years. GLP-1 receptor agonists, they've been on the market for 17 years. The long-acting ones for about 15 years. The SGLT2 inhibitors came on in 2013. GLP-1s and GIPs, that came out in like 2022. So that's one of the younger ones there. So when we're talking about GLP-1s, SGLT2s, GIP, what am I talking about? Glucagon-like-peptide-1. Okay, I know I during my training as PhD, I remember getting into all like the reactive oxygen species, ROS, and all this stuff, and I was just like, whoa, my mind's blown with all this, how detailed it gets. But just so you guys understand, glucagon-like-peptide agonist, sodium glucose cotransporter 2 inhibitors, and then you have gastric inhibitory polypeptide. Okay, so that's where those names come from. So one thing I wanted to mention, you'll see at the top there, those SGLT2s. We're not going to dive into those a lot because they're not used as much. They thought they would have some promise because when you treat diabetes, the main thing is you're decreasing insulin availability and or sensitivity, or you're increasing urinary excretion of glucose. And so that's how you treat diabetes. So these SGLT2 inhibitors decrease blood sugar by increasing urinary glucose excretion. So they're not as effective, and we'll get into the effectiveness in a little bit, but they're not as effective as these other ones that specifically GLPs and GIPs. Some of the newer medications out there are the ones on the bottom, and you could see they're combination meds, and those are glucagon-like peptides, all these things there that are together. This was super cool to read. There's a study, it's 2013, I think it's just over a year old. Don't quote me on this one, I'm getting them mixed up because the same author published same article and published 2 articles in 2023 that we reference here. But this, I think this is what you guys need to know of, like, okay, what drugs are out there and specifically what they look like. You could see on the left-hand side in the top right, that's the ones that are approved now, right? Then you have more of the monotherapy on the left, and then in the middle, you have those dual combo drugs, and you have trizepatide, you know, you guys might have heard of that one already. And then more recently, you see that we have the even more combos there, the triple, oh my goodness, here, I just did something with the chat, the triple receptor combinations there, right? So wanted to kind of go through that. Some of the ones that I would love to kind of hit on, exenatide, that's one that was used, and I just want to see where it is here. I don't think we have that one. Yeah, that one's not on here, but that's one of the ones that you would hear. It's Byetta, and it's a synthetic form of extended 4, which is it's actually, it has a similar makeup, like a molecule of GLP-1, and it's actually from a lizard like this. It's in the saliva of what's called the Gila monster lizard, which is really interesting, just because that's so random, right? It was in stage 3 trials. They found that like it worked pretty well twice a day. It was extended release. They're working on other stuff with that one, but the main thing that I wanted to hit on, oh dang it, here we go. Main thing I wanted to hit on when we're seeing this thing here about like all these different phases of clinical trials, I wanted to just take a minute to go over that, because everybody might be like, wait, what's going on? So to get us, and I'm just going to go over the top here, you could see phase 1, safety of the drug. Phase 2, effectiveness. Is it doing what it needs to do? Is that it? Phase 3 is the comparison. How is this new treatment, this new drug, comparing or better than the standard treatment than what we have? Okay, so you're comparing them. And then stage 4, it's pretty much on the market. It's just more long-term stuff and looking at side effects that come up and things like that. I wanted to put this out there because I don't know how many of us really take this into consideration. It's a process and it takes years to do, but when something's in phase 4, they're still receiving more data. It doesn't mean that things are like, oh, cool, we're good. It's just the fact that in those phase 3 trials, when they're looking at thousands of people, they're like, okay, cool. Not a lot of people got hurt. Some did, but not a lot. So we could let it go. And I know I'm kind of just, you know, downplaying that. I'm very thankful for the drugs that we have and the processes that we do have in place. And we need to look for the gaps, because there are some things that we don't know. And I think, well, if you haven't, if you look up Ozempic stuff on YouTube and things like that, you'll see some of the really sad stories of people that have died. Like that, like what? Like from trying to lose weight, and that happens. Like we can't allow that to continue. So with these drugs, I want to go through a few of them that we have, and mostly the ones that you'll hear about. You guys might have heard of Trulicity. And that's specifically dulaglutide. So that's one that you might have seen. I just want to see where that might be. I don't, but anyway, we have others one though, liraglutide, that's specifically Victoza. It's also called Sandexa. It's the same thing as, it's right up here, this one, the liraglutide right here, top left up there. Semaglutide, that's the one that you have with the weekly injections. It's Ozempic for diabetes, Wegovy for weight loss. Now, it's even approved in children greater than 12 years of age, which is disturbing to me. There's an oral there, and you can see that at the bottom, the semaglutide, that's Rybelsus. And so that's one there that's taken, I think it's two, I know there's two dosage, it's 7 milligram, 14 milligram, but it's also a daily drug. So people are looking for the pills, but the injections are, you'll see with some of the stuff that the injections are a bit more accessible to the body there. When we go up to this middle place here, this trizepatide, that's known as Zepbound as well. And you could see it's a GIP and GLP-1 dual receptor agonist. So the reason I'm going through these is I wanted you guys to kind of get an idea of the language and the different types of drugs as well as their common names, because when you see them, you'll see it in the little parentheses. You might see like, okay, here's, you know, trizepatide. Well, I mean, here you'll see like Zepbound, and then it will say trizepatide something or other in the parentheses there. So you might be able to determine what that is. One thing that we can't ignore are the side effects. Each of these drugs, the GLP-1s, they're going to have effects of like nausea, diarrhea, but anecdotally, what we've seen is constipation is more prevalent than diarrhea than anything else, and it persists versus being like transient, as some of the medical things say about these drugs. There's vomiting, of course, decreased appetite, abdominal pain. You're slowing the gastrointestinal tract down, and we'll get into that a little bit. And so I'm gonna move on here. So what are we talking about here, right? Like the mechanism, why these drugs, what's happening with them, right? So we're gonna hit on the main players first, GLP-1 and GIP, right? Okay, so this is showing the similarities and differences between GIP and GLP-1s, the two incretin hormones. Incretins are gastric polypeptides. So what that means is that they're metabolic hormones. They stimulate a decrease in blood glucose levels upon nutrient intake. Okay, so that's what incretins do. They come from the gut, and they include glucagon-like-peptide-1, which is GLP-1, and also glucose-dependent insulinotropic polypeptide or gastric inhibitory polypeptide. I like the shorter one, gastric inhibitory polypeptide, so GIP. These two incretins, they enhance insulin release after a meal, so through something called the incretin effect. And it's a phenomenon. It's a phenomenon when oral glucose, so food that you eat, causes a greater amount of insulin release than glucose that's given through an IV. Okay, so but it results in the same blood glucose level there. So that's what it is. In someone without diabetes, the incretin effect is responsible for about 70% of their postprandial insulin. So that's after a meal, 70% of their insulin. That's what this incretin effect is responsible for. Now, someone with type 2 diabetes, the incretin effect is impaired, contributing to that insufficient control of post-meal glucose levels. All right. GLP-1 and GIP stimulate the beta cells in the pancreas. Okay. They release and once they stimulate that, you could see on both sides of the pancreas in the middle of your screen, insulin release goes up. That helps lower blood glucose levels. They also, if you go down to the gastrointestinal tract there, and the GI tract at the bottom, they slow digestion, keeping food in the stomach longer. That also might prevent blood sugar spikes. Think, if you're a dietitian, right, when you're thinking about medical nutrition therapy for someone that has blood sugar control problems, what do you recommend? Fiber, right? That's why we recommend it. Stuff stays in your gut a little bit longer, keeps the blood sugar from spiking, okay? So what's the difference though? The difference is that GLP-1 inhibits the secretion of glucagon. Glucagon is a hormone that helps bring glucose out of storage and into the bloodstream. So I'm not going to get into where it comes from in the pancreas because it comes from different cells, but just wanted to highlight that. I wanted to talk about amylin, okay? Amylin is something new, and I'm going to flip back a little bit. You're going to see, what do we see here? AMY. That's amylin. This is a new one that came out, okay? And so I'll talk about the name of it in a little bit. I thought I mentioned it, but we'll talk about them in a little bit. But main thing is amylin is produced by the pancreas, specifically the same cells that produce insulin. So specifically the beta cells, right? Okay. And so what we're going to be looking at here is this side here, because the the mind side. That's where we're thinking here. But these, the beta cells inhibit food intake. So you have a decreased food intake, right? So you're getting satiety signals, and you can see it's working on those other hormones, leptin and peptide YY. If you go back to Jess Campbell's hungry brain thing, you'll see that's what happens when you have hunger or when you're full, right? So we'll go with that. It delays gastric emptying, and it decreases blood glucose levels. So that's what's thought to actually contribute to some of that decreased body weight there. Okay, so that's where the theory comes from. It's not very complicated, just that's what it is. But you're going to see amylin in some of these drugs that are coming on the market now because of the trials that they're going through. So when the receptor agonists, when you're looking deep through them here, the main thing that I wanted to talk about with this was how these GLP-1s and the GIP agonists mediate weight loss from activating some of the brain regions, okay? Specifically the hypothalamus, the hindbrain, and lateral parabrachial nucleus, okay? These are all regions, those three regions, all play a role in regulation of appetite, food intake, what you like to eat, so food preference. So you think of hedonic food stuff, like foods that are appealing to you, reward as well, and also when you say, I've had enough, okay? So if these work on those mechanisms in those parts of the brain, it leads to eating less, right? But what were we talking about before with that hungry brain? It's tricking us. It's tricking the brain into that. So what happens is your brain's like, cool, I'm good, but your body is dying. I know I'm being very blunt and perhaps even dramatic here, but the truth is, right? When you're not getting enough food, what's happening over time? So what I wanted to explain here with this, the GLP-1s, again, you see how it affects the gastrointestinal tract and everywhere else. Something I did want to mention is that some of the literature shows that GLP-1s, specifically by limiting that GI mobility, the motility and the secretions in there, it might be playing a role with the phenomenon called the ileal brake, and the dietitians in the room might understand what that is. But if you think of your small intestines, you have the duodenum, jejunum, and ileum, the three parts of your small intestine. The ileum is the last part there, and that ileal brake is a feedback mechanism that regulates the transit of nutrients throughout the course of the GI tract, because when you keep things in the small intestine, that would be more time to absorb things, but then you also might get constipated. Just there are pluses and benefits, however you want to look at it. But we just want to mention that because that's a big role that I think needs to be explored, especially when someone has disordered eating and then adds a GLP-1, further complicates that situation there. When the GLP-1 receptor is expressed by peripheral and central neurons, okay, in addition to the pancreas, etc., right? So when we think of these GLP-1s centrally on the hypothalamus, again, it messes with those homeostatic circuits and saying that, like, oh, things are cool when they might not be with food intake, okay? In the amygdala, they reduce food intake by actually increasing the feelings of stress or discomfort as well. That's not to say you're sitting there like, oh, I'm stressed out, but what I mean is that it's sending that signal to the brain, and it's causing a decrease in food intake there. Okay, so what I wanted to show in this is that activating both GIP and GLP is quote unquote attractive because of the combination of the mechanisms of these drugs. It's thought that they can enhance glucose dependent insulin secretion and decrease energy consumption, right? So if that happens, and then also increasing insulin sensitivity, that's one, beneficial for the therapeutic effect for someone that has diabetes, but it might also indirectly affect weight loss there. So next thing I wanted to show that we cannot ignore with any of this is the gut-brain and microbiota axis there, right? So this shows the main pathways of potential communication between the gut and between the gut microbiota and the brain and the gut cells itself. You see the vagus nerve in the middle there. That's the main one that's going to the brainstem. You could see GLP-1 is to the right of that there. You could see that that's something that we cannot ignore. So when we're using these drugs are going to have an effect neurally again, right? So that's the main thing that we want to that I want to highlight with this. We can get into the whole system with this, but the main thing is you see these enteroendocrine cells on the right side of your of this diagram. Those enteroendocrine cells, the EEE cells, you might hear them, they represent a small amount of the gut epithelium, but they are critical to homeostasis. There's 10 different types of these cells, and that there these different subtypes, which we'll get to here, they secrete these specific agents that we're talking about. And not the agents, the drugs themselves, but the hormones, the GLP-1, GIP, you could see. And so if you look at the K cells here at the bottom, and you can see location, proximal small intestine. So that's in the duodenum. That's closer to the stomach there. Proximal is closer to the body. So that's what that means. Then in the L cells, you have distal small intestines closer to the colon. You have the GLP-1s there as well, in addition to serotonin and whatnot. But it's, again, driving home the fact that when we are looking at these, when we have nutrient deficiencies or insufficiencies, especially with eating disorders, and also with taking these drugs, we have to consider what's happening at that cellular level, because it's the gut-brain connection. It's going to affect us neurologically. Okay, I'm going to pass it on now to Randy for a case example to kind of make this a bit more realistic for you guys.
Thank you, Sean. And I'm so glad that you mentioned the idea of that gut-brain connection, because I think in all of the biology that you're talking about, we really have to also consider that our brain gratefully is attached, to our body, and that, in the way that we're looking at understanding satiety and all of the other aspects of things that we're working with people to understand in treating and working with individuals that have eating disorders, that it's a much more complicated system than just looking at, how these things work in the body. They also impact how we think about how things work in the body. So if we could get to the next slide, please, on the case example. I'm going to talk to you about somebody who came in my door. And this, remember, was in 2021. So this is, somebody who came in. She was at the time a 32-year-old cisgender female with a 10-year history of binge eating disorder. There was co-occurring trauma. She had been in treatment for about 4 years for a binge eating disorder at this time. And she was actually making some progress and progression in recovery, as to be expected, a little of this. But, all in all, the ability to live her life and not, deal with the occurrence of binging, and being able to have a healthier relationship with food, and just all of the ways that we love to see people moving through, working in eating disorder recovery. So all of that had been happening, and that, I think I started seeing this individual probably in 2017, maybe 16. And in 2021, this is, when this particular person was in my office. So all this was great until 2020. And we can all know what happened on March 13th. It was actually my birthday. So in 2020, we hit the pandemic, and like many individuals, it's not surprising that this person had some isolation related to the fact that no one was leaving their homes. There was a lot of re-trauma related to dealing with family situations and dynamics that were really traumatizing to her and her, just situations. It was very difficult, and having to go back to a home environment where, like, a lot of judgments and food talk and all of that kind of stuff was happening. This person definitely became more clinically depressed per her psychiatrist, so that was something that happened related to isolation, depression, and also the fact that the movement, you name it, that there was binge behavior, there was so many different things, but she did gain weight during the pandemic, and that was just what it was. I think that was an uncommon experience for a lot of people. And in addition to this, during that time, as she was uncomfortable and upset, and all of the, behavior started to come back. She was also diagnosed with impaired glucose tolerance. Her A1C was just starting to get a little bit more elevated there. So we see it there at 6.4. Next slide, please, Shad. So, if we look at this individual, we were looking at this idea of like, we're now back in treatment for the binge eating disorder again. And, she's willing to come in, and we're working through eating meals and snacks, untangling her guilt, working through all the things as you can read: food exposures, movement for joy, taking some nice walks outside, and she loved actually to dance. So that was like, we're getting back into that stuff. And had hooked her up with a movement specialist, increasing her worth and connection. So actually like being with other people and eating with other people, and really working on this idea of like not focusing on her weight. But, she went to her psychiatrist, and while the urges were still high and she was progressing, the psychiatrist felt that with the, pre-impaired glucose tolerance, pre-diabetes, and the fact that this was really hard for this individual, that the semaglutide was going to be the way to work through this. And I think that, they thought that would treat her, that the thought was that it would treat diabetes, that her confidence would come back and she would feel better and better, and that the urges would decrease. And, I think I reviewed my concerns with the psychiatrist and the client. And I think the idea of, the understanding of, really, when we talk about decreasing this sort of craving idea, and sort of, this is I'm going to fast forward a little bit. I think Katie will talk a little bit about food noise. But I think this was this was sort of the reason that this psychiatrist felt that this client would really benefit from this. In addition to potentially physiologically, helping with some impaired glucose tolerance, she really felt that the idea that food noise would be the thing. And I think, food noise, as I explained to the psychiatrist, was really like, it's going to name the experience of thinking about food, longing for food, planning our next meal. And like, that's a kind of a slick rebrand for some of the things that I was saying. Like, we've been working on that all along. Like, what's the difference? Like, isn't that kind of what we've been working on? And these are the most basic human drives of hunger and appetite and craving. But now this was starting to be framed as like, these are problems rather than features of our bodies and our physiology. And I think that, the idea that, food noise is an expression of hunger, and the body's natural response to inadequate fuel is something that we really need to think about. I think that, when this person came in, being able to explain that to her psychiatrist and understand and say, these are all the things that we've been working on. I think that the thought was that it wasn't happening fast enough, because if we kind of go back to, 2016 through 2021, we actually had done a lot of this. And even if we look and see in the work that we were doing, that she was actually like, her food noise was coming down. It wasn't gone, but we don't want it gone, because it's part of the basic human drive to eat and experience pleasure and have cravings and other things. Sean, can you continue, please? So this client started semaglutide, and she, did have some of the side effects. Actually, I think I saw her, within the first week that she started, and she was late to our appointment because she had to pull over on the side of the road to get sick. It really, the GI effects were really difficult for her. She did see that as she, was taking this, that they did get a little bit better and worse, but there was usually she could anticipate that when she took the injection that there would be a side effect within that day or the next day, and that was really difficult, and actually impeded a lot of the other ability to sort of like move and do other things as well. Like she said that movement was better, but interestingly enough, she moved less because she's like, well, I'm losing weight, it's good. Like, I don't really need to do any movement. She said that her connections were better. She felt like the idea that she didn't, she wasn't as hungry, so she was eating less in front of other people, allowed her to have connections again. A lot of sort of looking at this as like, was this better or not? Yes, if we're really just looking at people in terms of numbers, her A1C did actually decrease. She did lose 40 pounds over the course of the year. And she reports that her urges are not present. I think that the idea of, better, faster, we definitely want to help people through this, but there's a part of so much of this work. And I know, Katie, you're going to talk a lot about this. And it's this combination of, like, I don't know where everyone is on everyone else's screen, but I have Sean at the top of me and Katie right below me, of like merging together the brain and the science, where like you come together and here is a whole person, right? And so for somebody to actually experience, any kind of, change in how they might look at things, or in the acceptance of who they are, and really working through a lot of these deeper, and more, I would argue, more significant things, is actually something that can't be minimized. So I feel like, she reported the urges weren't present. We continued to work together for another, year or so. And then she's like, I think I'm good.
Great. So, I think we're getting to be a little bit short on time. So, I might go through some of this quickly. So GLPs obviously appear to have a lot of positive physiological and psychological influences for many people who take the medication. Like that just seems to be what things are. And of course, we want our clients or patients to experience themselves and their lives positively. The impact of the dawn of these agents on eating disorder treatment, on fat liberation, on diet culture are immeasurable and not always as positive. There appear to be a number of really important and positively impactful health benefits to GLPs that have nothing to do with weight loss. And we have to be really careful when we're looking to GLPs to like solve the problem of obesity, when obesity may not really be a problem that needs solving, at least any more than weight stigma itself needs to be solved. We still do not know what the impact of GLPs will be on long-term weight control, mental health, or what long-term use side effects may emerge with prolonged use at dosages that are indicated for weight loss and not just management of insulin resistance or type 2 diabetes. A lot of these drugs have been on the market for 12, 17, 20 years at doses to treat insulin resistance or type 2 diabetes. But at these mega doses and some of the medications that are forthcoming or that are sort of like spin-offs of the original. I worked in entertainment for a long time, if you can't tell. Like a lot of these drugs may have different and more serious long-term side effects that we just don't know about yet because they have not been in our bodies for more than 2 to 3 years at this point. So there's some evidence that research is bearing out, even by the drug companies that make these GLPs, that at about 60 weeks, there is plateau and regain even while still taking the drug. And everyone who, well, I don't know, everyone, most people who stop taking the drug do experience some regain. So it really is a drug that one might have to take for life. But even if one is taking the drug for life, one may not see the sustainable weight loss that is so very intriguing in the beginning of people's journeys on GLPs. There is some evidence that GLPs can modulate anxiety and have some use in supporting substance use recovery. They appear to reduce inflammation throughout the body, and data points to improve cognitive function as well as protective factors regarding onset of diseases, including Alzheimer's. So we're really looking at how inflammation works in the body and how inflammation interacts with our psychological and physiological well-being. And we're looking at mood outcomes for GLPs. It's really important to consider that anxiousness about body shape and size is a common trigger for anxiousness in all size people, and especially those in marginalized bodies who walk through the world consistently and perpetually facing discrimination that's bold and microaggression. So when someone is on a weight loss journey, it is pretty common to see a lot of these anxieties begin to reduce because there's the hope or the experience of being less discriminated against or being closer to that center of power. Next slide, please. So back to food noise. So a working definition for food noise, because there is not a commonly agreed upon one yet, is heightened and or persistent manifestation of food cue reactivity, often leading to food-related intrusive thoughts and maladaptive eating behaviors. But this seems pretty incomplete, and to leave out, sort of what Randy was touching upon, the very real experience of thoughts of food being some of our very first hunger cues, right? So our bodies are designed to think about where we have the most pleasure nerve endings, right? In our mouths and in our genitals. We are designed to eat and to have intercourse, right? With pleasure, with nerve bundles in these two places, because that's how we as a species continue, right? So taking away some of this stuff actually has greater implication than just pursuit of a smaller body. GLPs act on the central GLP-1 receptors and the central satiety center, causing a feeling of satiety and reducing food intake, which is how weight loss is achieved. It does not appear that there's a mechanism of the drug itself, that it is just really calories not taken in, that is the mechanism of weight loss. It's a little more nuanced than that, but generally speaking. It's also important to know that there are many factors that can impact hunger, including stress, including sleep, including anxiousness, and including the neurobiology of somebody who is predisposed to have an eating disorder. And we haven't really had a chance to look at the impact of these drugs on the brain of somebody who might be might have some eating disorder wiring. Next slide, please. So we've talked a bit about food noise, and now we get to weight cycling. And so weight cycling is a really common experience for people who have been dieted from childhood by doctors or parents, or have dieted themselves throughout their lifetime. And what weight cycling is the weight suppression in a body that is naturally a certain, maybe larger size, to weight loss. And then over time, even with the same behaviors that caused or contributed to the weight loss initially, there's a biological drive in our bodies to regain that weight. And then we say plus tax, right? Because the body's like, oh no, there's a famine, I better recoup that weight and then add on some tax just in case there's another famine. We won't be at so much risk. So one thing that's so important to remember and acknowledge is that repeated dieting and weight cycling have been implicated themselves, right? Not fatness itself, but the weight cycling itself have been implicated in an increased risk for eating disorders, other psychological and physiological disorders, and multiple comorbidities, including type 2 diabetes, hypertension, some cancers, bone fractures, and increased mortality, right? So a body would prefer to stay at a consistent weight than to go up and down and up and down. And the weight cycling itself is the thing that causes or is contributory to a lot of these negative outcomes. And the negative psychological impact of weight cycling can't be oversold. Remember, we can't separate mind from body anymore. And GLP agonists really reinforce the model of mind-body as a single system, not as systems that work, separately from one another. The brain of a person in caloric deficit is a brain that is at risk for fixation on food, fixation on body, and increased cognitive rigidity. Next slide.
Y'all, the delay on my end, like getting a little bar at the bottom, so I apologize. But so talking about that with the weight cycling, what are these drugs show, right? And Katie mentioned some really great points that we didn't hit on before, but just one thing that we wanted to hit on this was specifically the effectiveness. And I put quotes around that, like, what are we looking at? This graph shows, and this is from a couple years ago, but with the exception of semaglutide at 2.4 milligrams, the average percent body weight loss is in the single digits, with only a fraction of people achieving and maintaining that 10% weight loss at like a tolerable dose, right? So while that's clinically meaningful, like it's not very effective when you look at, okay, say bariatric surgery, and that's what this shows here in this. Okay, these studies, please check them out if you're interested in this. You can get into the details. I don't want to just rattle off percentages, but with this, you see the different percentage weight losses here with that. Something that I wanted to show you from the STEP trials, and those are other ones you could see. You have the STEP trials are from like the middle of the slide to the right. You could see the weight loss there of what's being done in the study specifically. So the main thing is at 2 years, which is the third set of bar graphs, you'll start to see a decline in effectiveness. Okay, that fourth set is from the SURMOUNT trial, which it's the efficacy and safety of trizepatide once weekly in participants without diabetes. So that's where the acronym comes from. But what you can see is that this study was, again, just over a year. It's 72 weeks. And so that's something that we need to take into consideration. This one specifically, this is a phase 2 trial. This was published, I forgot what month it was specifically, but it was published over the past year. It's a phase 2 multi-center double-blind randomized placebo-controlled trial. So a lot of checks and balances in place with this one, but this is for the retatrutide, and that's one of the ones that you saw on that graph that I showed earlier. The results show weight loss is dose dependent, and that's what we see with the other GLP-1s and the combinations as well. Greater dosage, you have greater weight loss, but that also comes with greater chances of side effects with that, and that's problematic there. What you can see at 48 weeks, which is almost a year, you could see that most of the other lines, and I know that last bottom line for the 12 milligram one was, it's plateauing. If we drew that out, it would be plateauing, and that's what we see here specifically on this last slide here. So this is one of the other STEP trials. They had like 1 through 8, and so just for your information, but what you can see here is how once we start getting out at these longer timeframes away from the drug initiation, weight plateaus and then actually starts to go up. So that's something that we need to take into account. We need to know that at 68 weeks of someone taking semaglutide, and we're using semaglutide, that's the research that we have right now. We see other ones, but this is the long-term data that we have. We start seeing that plateau and even perhaps a decrease. And that's what Katie was hitting on before. We can't ignore that. That's going to lead to this weight cycling problem that we'll see when someone is being, I love how Katie said it before, dieted, when they have been dieted and when they diet. Okay. So pass it along to Katie for this one to wrap us up.
Thank you. We need to look at how our culture is looking at patients and prospective patients for utilizing GLPs. When we look at kids, and when we look at how people's perception of themselves and how they see themselves in the world and how they see the world relate back to them, childhood is a tender time. Childhood is also a time when bodies are changing and growing at very rapid rates, and not always equally to peers. And so it's also really important to look at sort of attachment theory, and what happens when a kid learns in their culture that their body is wrong, but then learns from their parents and their doctors also that their body is wrong, and what that can do to the psyche of some young people. So there's already documented grave physical and psychological shadow side to dieting children. In 2022, a popular GLP-1 was approved for use in adolescents after about 201 young people ages 12 to 17 completed a 68-week trial, a little more than a year after the drug was approved for use in adults. And many people who work with children who experience weight stigma, bullying, and discrimination at the hands of family, medical practitioners, and peers understand why parents and doctors in this thin as health obsessed culture would be drawn to these medications, some pointing to the very real pain that their children in bodies that are considered larger experience as a result of diet culture. There are big ethical questions about long-term use of these medications when started in puberty, with decades of life ahead, when the one clear fact is that weight regain is nearly 100% guaranteed when people stop using the medication, or even if people continue to remain on the medication. Children learn from their environments, especially their families, about how to think and feel about themselves and their bodies. And for many children, parents make the decision on the child's behalf to start a child on weight loss medication, which really strips the child of agency and a chance to learn about their own growing and changing bodies, and to develop a healthy relationship with themselves, and to develop interoceptive awareness, and to learn self-trust surrounding food and body. What happens when a child develops an eating disorder while on a GLP? How can we tell? What happens when a child goes through puberty and completes adolescence in a weight suppressed body? What happens when a woman who has been on a GLP since she was 12, right? We don't know the outcome of this yet because we haven't had these drugs around long enough to know this, but what happens when this person who has been on a GLP since adolescence gets pregnant and maybe has to stop taking the GLP during pregnancy? We just don't know what these really intense implications could be looking forward, especially when we're looking at kids who may be predisposed to eating disorder. Next slide, please. So moving away from kids just for the sake of time, it's important for us to look at GLPs because they are here to stay, and how we weave in harm reduction into our work with clients, whether we are, whatever our role is in healthcare or mental health care. Some people may desire to access these drugs for health-related reasons, but there's great prevalence in the public eye of use of GLP agonists for the sake of weight loss in people who may not appear to meet criteria. As with many trends, when celebrities tout designer products, the public desires to emulate that which is pedestalized and that which is trendy. So how are we as clinicians who treat people with eating disorders going to approach the fact of these medications? The clients will approach us for treatment gripping tightly to their medication, unwilling to stop, if even for a short period of time, out of fear of regain and or cessation of weight loss. For our clients in all size bodies interested in GLP use, we have to look at what drives this desire. What is the promise? What is the need deficit that our clients experiencing that they believe GLP-1 use or weight loss is going to solve? It's so important whether the client has disordered eating, an eating disorder, or hasn't shown either of these yet. It's so important to really understand why our clients are desiring this and explore with them, like, how is the desire just to be on trend, right? Or is there something deeper? What deeper is going on? Sometimes it's helpful to weigh out the pros and cons with clients who have already made a decision to start GLP treatment. What are the immediate risks worth what might be, minor to moderate benefit? What about long term? There's risk to every intervention we choose to recommend across all, healthcare provider platforms. There's risk to every intervention we choose to recommend. So it's really important for treating clinicians, especially clinicians in privileged bodies, to hold space for clients in less privileged bodies to feel empowered around the choice to use or not use these medications. So that's a little bit of what I'm talking about in terms of harm reduction. Recovery includes learning to nourish and trust the body's natural cues, and that can be, sort of T-boned by use of GLP. Recovery includes learning to manage maladaptive eating disorder-based urges, eat adequately, eat regularly, and without obsession, and to learn to manage and decrease distress surrounding hunger cues and fullness, to distinguish emotional hunger and fullness from physical hunger and fullness. With these novel agents, slow digestion or dull, completely numb hunger and mimic satiety, many of the traditional tasks of recovery become a lot more challenging. So, typical indicators of eating disorders such as hair loss, rapid weight loss, weight suppression, GI symptoms, intense fear of weight gain, restriction of food and fluid, vitamin and mineral deficiencies, possible damage to organs, though which particular organs may differ from eating disorders and side effects from GLP agonists, feeling of guilt, embarrassment around food and eating, and suicidal ideation can be found among the side effects of GLP agonists and related weight loss medication. We have to be able to sit beside our clients with wholehearted investment in their experience and recovery. This is really when we come very basically down to unconditional positive regard. If we're looking at Rogers, looking at interpersonal, co-regulation and some of Kohut's theory, what is coming up for our clients that they didn't feel they had access to before pursuing GLP use? What non-weight loss benefits are they experiencing, and what value do they place on these findings and feelings and experiences? We may be tempted to remind our clients of the side effects, to remind them that the euphoria they're experiencing in the beginning of this journey may be temporary. At some point, exploring side effects and long-term outcomes is very important. However, timing is everything. Nothing we say will have meaning if our clients are not in a place to receive and metabolize the information that we're giving them. While we must not abandon our own principles and best practices, and the fact that dieting and intentional weight loss is never indicated for people recovering from eating disorders, that hasn't changed. We want to be careful to remain an ally to our clients so that the work of recovery doesn't fall away, even if someone is engaged in GLP-1 use. Weight loss does not cure body image distress or the collective trauma perpetuated by weight stigma and diet culture. It just doesn't. Some may say it actually perpetuates it. But as providers, we must continuously assess for what might be behavior attributable to eating disorder or what might be attributable to side effects of medication. It may be more difficult to discern relapse of eating disorder or development of eating disorder in GLP agonist patients. So we have to be open and curious. We have to be willing to hold space for the real relief and euphoria that some clients experience at the start of GLP use. And we have to be beside our clients with the grief that comes as part of recovery, and the grief that may be intertwined with GLP use down the line. To touch back on Randy's point with Maimonides, we don't know what we don't know. Keeping our minds open, really observing the work of our clients, really making our own our own feelings and biases for or against some of these GLPs, not only in the backseat, but maybe in a different car altogether, right? So we've got to sit beside our clients. We've got to understand the, ride that they may be on with GLPs. And we have to ground ourselves in the knowledge that our relationship with our clients is very important. We are there, yes, role to role, but also soul to soul. And when we can really root ourselves in the relational aspect, we have a much better outcome in helping our clients succeed, whether they continue to take GLP, if that's right for them, or they decide to stop taking GLP.
Thank you all. That was absolutely incredible. I can speak for everybody here, just saying how wonderful that was. I am going to provide both my email again and Jamie's email in the chat for those CMEs. I know we did have some questions roll through, so feel free to email those to me as well, and I can reciprocate them moving forward because we had some awesome questions come through. But again, thank you, Randy. Thank you, Sean. Thank you, Katie, for such an insightful presentation. I know I enjoyed myself, and I'm sure everyone did here as well.
Take care.
Yeah.
Sounds great, everyone. We'll see
Thanks.
you in the next session.
Take care.
Yeah.